Today I will talk a bit about quantification of coronary stenosis, whether there's any improvement using AI, and whether there's any improvement using the newer ultra-high resolution CT scanners. I will also discuss what is spatial resolution and factors affecting it, what is ultra-high resolution CT, and I will talk a bit about using AI reconstruction software as an alternative to buying a PC-CT scanner. I will talk a bit about some pitfalls when reporting coronary CTA scans for stenosis, which AI may not detect. Because of the time that I've been given, I will not be able to discuss CT FFR, CT perfusion, or CT plaque analysis today. Now, we all know there are three ways to assess images to quantify coronary stenosis when you read your coronary CTA scans. The first is visual estimation, or eyeballing, which is what we do every day. You can do direct measurements of stenosis on cross-sectional views, on long axis views. That's called manual quantification, or you can use the semi-automated vessel analysis software on your workstation, which is called QCT. When using visual estimation, it is not recommended to use thick slice 3 mm MIPS, which is often the default setting on your workstation. You should use thin slice less than 1 mm MIPS when reading your scans. The reason for this is that MIP images, MIP means maximum intensity projection, MIP images may obscure stenoses because the pixels containing high density contrast are retained while low density plaque pixels are discarded, and the resulting MIP image underestimates stenosis, or may underestimate stenosis. Using the software on your workstation, QCT accuracy for quantification of stenosis is limited. Even if you spend a long time on improving wall contouring and centering, it does not improve accuracy of visual estimation, but is useful as an additional tool. For example, to confirm visual estimation in difficult situations such as near an ostium when there's no normal nearby reference site, or when you have large calcified plaques present. You should also use the other tools available in QCT aside from diameter stenosis, such as area stenosis in percentage or minimal luminal diameter, mm². And of course, you can do coronary plaque analysis at the same time, which is why we still use QCT. At the same time, make sure you use the correct minimal diameter and reference diameter when calculating the diameter stenosis. This is the current recommendation from ASCI, which was just published this year, that it's important to use the average of two diameters, both for the lesion and for your reference diameter. What about using AI to quantify stenosis? In this study that was published last year, which was multi-center, multi-vendor, using the CT scanners of the 4 main vendors, AI software was compared to QCA using software from a company called Cleary, which has FDA approval, and you can see the analysis time was very short, and there was high agreement between the stenosis detected using the software versus QCA done in the cath lab. However, this software was not on site, and all the data had to be sent to the vendor. This is another paper published last year, again, multi-center trial with 4 major vendor CT scanners used. They use software from HeartFlow. Again, it's not on site and need to send the data sets to the vendor. Again, the time taken to analyze the software was very fast, but it still needed to be checked by a doctor before the report was released. And again, the accuracy is high. This is a paper published earlier this year in European Journal of Radiology from a group from China. AI post-processing compared to QCT software. Post-processing time much faster, workflows improves. Accuracy for diagnosing stenosis is similar to QCT, but again, the software results need to be checked by a radiologist. My recommendation is choose your AI software vendor carefully, because there are many software vendors out there trying to sell you software. Buy only AI software that has CE mark or FDA approved, needs to be on site. Your data set should not be sent outside your hospital and should be cloud-based. Also, the vendor of the AI software needs to make sure that they're continually improving and doing more machine learning of new data sets so the software can improve. Let's move to spatial resolution. Spatial resolution, or XY, in the XY plane is what is called acquired spatial resolution, is determined by detector width, detector geometry, X-ray focal spot size, and the display FOV, or image matrix size, which is usually 512 by 512, but these days 1025 by 1025 is available. The X-axis resolution, or reconstructed resolution, or through-plane resolution, is determined by detector row width, previously called effective slice thickness and slice collimation, and the reconstruction algorithm used by the vendor. Detector row width is the main determinant of the intrinsic longitudinal resolution of the scan. So what it means is that, again, I repeat, spatial resolution of CT is primarily determined by the detector row width. But smaller detector rows, detector size means increased noise and usually increased radiation dose to overcome the noise. With a PCCT, there may be a possibility to reduce radiation dose due to lower image noise and better contrast to noise ratios. Because of the increased noise, you also need noise reduction software, and at the same time, there is huge increase in the data sets that are generated, so you need to have increased server space as the data can increase by 10 to 50 times. So what is high resolution CT? The SCC definition is a CT scanner detector element with less than 0.25 along the Z-axis. All the scanners that we are currently using have had detector width elements unchanged since 2005. The ultra-high resolution CT scanners currently available for clinical use, there's the Siemens PCCT scanner, which can scan it in standard mode 0.4 mm scan collimation, ultra-high resolution 0.2 mm scan collimation with a Z coverage of 2.4 centimeters or 24 mm. Canon has a CT scanner called the Precision CT, which has 0.25 mm detector, but with a Z coverage of 40 mm or 4 centimeters. There are other CT scanner, PCCT scanners in development, which are currently prototypes, so maybe it'll be 2 or more years before we can even think about buying them. There's one from Philips that has detector collimation of 0.275 and a Z coverage of 17.6 mm. Canon has one with detector collimation of 0.2 and a Z coverage of 38 mm. GE has one also where the detector collimation has not been disclosed, but we think it's less than 0.4, and it has a wide detector coverage of 80 mm or 8 centimeters, which might make it easier to perform cardiac CT. I want to talk a bit about our PCCT scanner, which we installed in May last year. It was not a prototype, it's a commercial version, and we published our results of the first 92 patients that we scanned. With the Siemens, you can do ultra-high resolution scanning mode, 0.2 mm, but you have to scan at 120 kV, and there's only 2 ways. You can do spiral, retrospective scanning, where the scan time is very long, or you can do step and shoot, where the scan time is shorter. With quantum mode using 0.4 mm, you can scan using 90 kV, and you can scan in 3 modes: flash, step and shoot, and retrospective spiral. Quantum Plus node was not available at the time of this study. So here's an example of a large calcified in the plaque in the LED, which shows no blooming. A stent again with no blooming. Very nice pictures. The question is, do the newer high-resolution CT scanners make a difference for quantifying coronary stenosis? Because with smaller detector size and better spatial resolution, there's less blooming and beam hardening artifacts. Well, these are the published papers With the Canon 0.25 detector with scanner, you can see the positive predictive value has improved from the normal scanners or traditional scanners, which is usually around 70 or 80. With the Siemens, the positive predictive value is not as high as we would expect, but it could be related to the small size of the studies, so we need to await further studies. There were 3 studies published recently comparing stenosis measurements between patients who were scanned twice, once on a conventional CT scanner and once on an ultra-high resolution PCCT scanner, and they all showed reduction in diameter stenosis using the PCCT compared to conventional scanners, and that many of the patients could be reclassified to a lower CAD-RADS category. Now I want to talk a bit about the radiation dose with our PCCT scanner. You can see that when we scan with 0.2 mm collimation, because we had to do retrospective gating, the dose was quite high, on average 7.2 millisieverts. With using 0.4 and step and shoot, the dose was lower at approximately 4.29 millisievert on average. And you can see that our results are similar to other published papers. Our average was 7.2 mm. Here's a paper that was 13 millisievert on average, another 13.92 millisievert. This dose was much lower, but they didn't do retrospective gating. They did step and shoot, which is not really practical in clinical practice because the Z coverage, as I mentioned, is 2.4 centimeters. However, since May 2023, there have been some improvements because PCCT is a new technology. Now we can scan using 90 kV, and you can see the effective dose has come down, and of course the image quality is very good. But what if you cannot afford to buy a PCCT scanner? Are there any alternative solutions to buying a PCCT scanner? Well, first you can wait for the other vendors' PCCT scanners to be available and hope the price will come down, which I think is unlikely because of the high cost of development of these scanners. Or you can use deep learning AI-assisted reconstruction software to improve spatial resolution. Deep learning image reconstruction software is available from a vendor, and it's called Peak. It's trained on ultra-high resolution datasets scanned on a CT scanner with a 0.25 mm detector width. This software is said to produce sharper images and increase spatial resolution. And once the software is available and trained, it is applied to your normal scanner, 0.5 mm detector width scanner called the Equilibrium Prism, on-site where it does not continue to learn. And the on-site reconstruction of software or images after scan acquisition at the radiographer's console takes approximately 20 to 30 seconds. Because it needs AI, they need to use these GPU chips from NVIDIA, which cost $50,000 US, so that's why these scanners and the software are expensive. This is our Canon Prism, and we use Peak software and reviewed 287 patients that were scanned, and we presented this paper at KCR last year. And you can see that the signal-to-noise ratio has improved significantly, and at the same time, the radiation dose on average is only 2.7 millisievert. Here's an example showing image quality, and you can see with this software, you can see plaques so much clearer than with the software that we were using previously. Here's a mixed plaque. Again, you can see the images are much sharper and there's better definition. Now, let's move on. The mistakes most often made when we read scanners may be due to artifacts from calcified plaques or other reasons. And the AI software for stenosis may not help you. The most important is false negative scans, where we underestimate the degree of stenosis or we miss a stenosis, because this can have serious impact on patient prognosis and management. So for example, this is a 67-year-old man with chest pain, and you can, is there any disease in the left main? At 0.5 mm, you don't really see anything. At 3 mm, you don't really see anything. But you notice that your crosshairs are not angled through the orifice of the left main. So you must always angle your crosshairs or MPR images through the orifice, all right? And you can see there's disease in the orifice of the left main. So this is something you do not want to miss. The question is, will AI help you when it's available? It will probably find it for you. But until you get this AI software, make sure you do this every day for every case. Here's a patient with chest pain. This was reported as showing the LAD shows no significant stenosis, and you can see the software is going up there. But did you notice something? The normal anatomy of the LAD is it always goes in the intraventricular groove and should be here. Anything out here laterally situated is the diagonal branch. So let's just go back. Here's the LAD, and then you don't see it. There's no contrast there, and what you're seeing there is the diagonal branch. So what's happened is the software has tracked up this wrong vessel, okay? And there's actually an occlusion of the distal LAD. So you should not miss this, because this mistake is because of using 3D images and automated software to read the scans and not knowing your basic anatomy on CT. I'm not sure if AI will detect this until it's trained to know the normal anatomy of LAD. Here's another patient, 44-year-old man with chest pain. We reported the CT scan as showing mild stenosis in the distal left main. You see some calcified plaques opposite each other. But because he had persistent chest pain, he went to the cath lab and you can see a stenosis in the left main, in the distal left main, which we missed. Well, the reason for that is because of the calcifications that are opposite each other. They can cause partial volume artifacts and we can miss it. I'm not sure, again, using AI software may help you, as it's trained on usually on existing CTA scans, but not with associated cath lab results, perhaps in the future. But I think AI would miss this. So in conclusion, quantification of stenosis by CT is still best done by visual estimation. It's the fastest, easiest, and as accurate as other methods. You use QCT measurements to help you in difficult situations. Excuse me. Using tools such as MLA or area stenosis percentage, but you should know the limitations. AI software is here and will be another tool, needs to be on-site and cloud-based. Many vendors available, buy only CE mark or FDA approved, improves workflow but still needs human radiologists for quality control. The high-resolution scanners are here, seem to improve positive predictive value of accuracy of quantification, less false positive, and can reclassify patients to a lower CAD-RADS category. If the CTA result shows mild stenosis, especially with calcified plaques, always be guided by patient symptoms and your clinical judgment, as you may need to go to the cath lab to exclude a false negative diagnosis by CTA.